Okay. Hi, very good evening. Hope you're all doing fine. So I just opened a new brand of 4 pens. So I took some time for this. Today we shall have a discussion on few questions, general questions pertaining to dentistry, covering various aspects, right? So we have coined or termed this video as SAQs. SAQ is nothing but self-assessing or self-assessment questions, right? So SAQs, so I'll be asking you questions, right? It can be image-based or illustration-based or a general type of question pertaining to a subject. And let's see how you're going to answer. And after the questionnaire and after you give me the answer, we shall have a brief discussion on the same, right? Okay, I hope I'm audible and I hope it is streaming fine, right? And also I think I could minimize the amount of light reflections on board. If you still find it difficult, do let me know. Okay? Right. So first we'll start with the first question. We'll have an illustration based discussion, right? Yeah. So coming to the first question. So this represents the teeth of a patient, right? So what Kennedy classification does this charting fit into, or what Kennedy's classification does this representation give? So that's the question. I hope the numbers are visible, right? So what Kennedy classification does this charting fit into? So as you know, we have different classifications for your edentulous jaws. So Kennedy's classification and Applegate rules, we made one video also and we posted in our e-classes. So you can refer to that for more information. So in case of maxilla, which Kennedy's classification is it, and in case of mandible, which Kennedy's classification fits into? So as you all know, Kennedy's class 1, bilateral posterior edentulous areas, right? And class 2 is unilateral posterior edentulous area. And you have class 3, unilateral edentulous area with teeth on anterior and posterior aspects, like it's a saddle, right? You have edentulous area bounded by teeth, natural teeth anteriorly as well as posteriorly. And class 4, which crosses midline, edentulous area crossing midline, isn't it? And then you have modification spaces, right? So based on the concept, try answering this. So you have the teeth here in a given patient. So which Kennedy's classification fits into for maxilla and for mandible? So for maxilla, yes? Good. So it's a bilateral posterior edentulous area, right? So Kennedy's class 1 and mandible yes, Kennedy's class 2 modification 1, isn't it? So you have this in third and fourth quadrant, 6 and 7 are missing. In third quadrant, 5 and 6 are missing, right? So the posterior most edentulous area determines this classification, right? So we are saying class 2 modification 1. In case of your upper arch, you have posterior teeth missing on either side. So it's a bilateral edentulous area on the posterior aspect. Good. So in maxilla it is Kennedy's class 1. In mandible, that is Kennedy's class 2 modification 1, right? Yes. So I've given you a representation, right? So I've asked you Kennedy's classification. So that's one way in which you can have a question, right? Now let's move on to the next question. What do you mean by the term microleakage? So what does the term micro leakage mean? What does the term micro leakage mean? You need not really define it, but you can explain in your words, own words, like what does micro leakage mean? Because once we go through the meaning of micro leakage, we will also discuss the consequences of micro leakage. Yes, sure, engineering, good. It can be leakage of fluids, it can be leakage of bacteria because of space which occurs between respiration and tooth structure according to Abhishek. Penetration of saliva into respiration. Good. Yes, anything else? Is it only the fluids and bacteria? I request every one of you to involve in discussion, because once you start involving in discussion, then active learning happens, right? Yes, percolation of fluids and bacteria because of space between tooth and respiration. Good. So microleakage, as you all mentioned, is passage of bacteria, fluids, or even molecules, or even ions along the interface of a respiration and a cavity. Right, the cavus surface, margin or the surface of a tooth, right? This is according to Kidd in 1976. So we have microleakage, and obviously we see microleakage in various restorations, right? It can be amalgam, it can be composite, it can be GIC. But with adhesive restorations, this microleakage can be obviously eliminated. Now the question is, what are the consequences of microleakage? What are the clinical consequences or outcomes, if at all there is microleakage? So microleakage, as you all mentioned, it is leakage of fluids or bacteria, or it can be molecules or even ions. So what could be the consequences of microleakage? Yes, Neetu, good. Yes. So microleakage can lead to marginal discoloration, isn't it? So there can be marginal discoloration, anesthetic appearance, and also, as I have been mentioning, microleakage can also lead to post-op sensitivity, which is in accordance to your hydrodynamic theory, right? Hydrodynamic theory. And also, because of movement of your bacteria, there can be even secondary or recurrent caries. Right? Good. And as a consequence, ultimately there can be even pulpal pathology. So these are some of the consequences of microleakage, isn't it? So you can have marginal discoloration, sensitivity, secondary caries, and pulpal pathology. Now, how do you eliminate or how do you overcome this microleakage since you have these drawbacks associated with it? So what are the means through which you can eliminate this microleakage? Sure, Anjani, you want to do re-restoration? Okay, you can go to the extensive way of treatment, but before that, why don't you start with simpler means or preventive means? So how do you prevent microleakage? That's my question. So obviously you can go for we have discussed this in pulp protecting agents in detail, right? So cavity varnish or base materials, liners. In fact, base and liners, they have specific purpose, but varnish is specifically indicated to seal the dentinal tubules and to prevent microleakage. And also we have this concept of self-sealing restoration in case of amalgam. Self-sealing. So what is this self-sealing? Why do you call amalgam or why do you consider amalgam as self-sealing restoration? So obviously in case of adhesive restorations you will not have this issue of microleakage, right? Yes, Abhishek. So what is self-sealing restoration? Yes, proper condensation, good. And why is amalgam considered as self-sealing restoration? Good, Dhanalakshmi. You say saliva corrosion, accumulation of corrosion products block the interface between your amalgam and tooth. Good. So you have your corrosion products. Right? So which seal the interface between your amalgam, restorative material and tooth structure where there can be potential space because amalgam doesn't bind chemically to a tooth structure, mechanical retention. So now another related question, name different corrosion products which are seen in case of amalgam, especially a low copper alloys, because high copper alloys corrosion products are eliminated. So what are the corrosion products usually seen in amalgam restoration? And we'll stop with this, right? We'll proceed with the next question. Yes, Preeti, Bernice. Oxides and chlorides of tin, right? Yes, various oxides and chlorides of tin. Good. Right, so we'll stop it here. We'll proceed with the next question, right? So anyways, at the end of the session, we shall have a brief summary of all that we have discussed so far, right? Now, coming to the third question. What treatment, please listen carefully. Yes, gamma 2 phase, good Abhishek. What treatment should dirty but reusable dental instruments undergo prior to sterilization and why? The question is, what treatment should dirty but reusable dental instruments undergo prior to sterilization. So before sterilizing, if you have dirty instruments which are reusable, so what kind of procedure do you perform before sterilization in order to eliminate that the dirt? And why do you have to undergo, or why do you have to perform that procedure before sterilization? So that's the question. Yes. Any better words than washing? Because we can use the same word washing for clothes and various other materials, right? Yes, Sonal. Sonal, I guess you are busy with your cousin's marriage, right? Scrubbing. Yes. So the scrubbing is something which is used for your hands, living objects maybe. Yeah. So this cleaning process or washing process or scrubbing process which you mentioned is called as pre-sterilization or decontamination. I hope you can see. Yeah, pre-sterilization or decontamination. But you said, Sonali, how you're busy in some marriage. Okay, fine. I have very poor memory. Maybe I'm mistaken. Right. So this decontamination or pre-sterilization is a procedure where you try to eliminate all the organic or inorganic materials that are stuck on your reusable instruments, because if you don't wash them and if you give them for sterilization, what happens is there is greater chance for survival of microorganisms in those organic fluids like saliva or blood, etc. Right? So this is decontamination or pre-sterilization. Now, the connecting question is, how is it carried on? You said we wash it, right? So how do you wash? So how is this decontamination or pre-sterilization carried on? How? With brushes and special soap, iodine, H2O2, ultrasound bath, good bread, you know? Yes. These instruments can be scrubbed manually or can be cleaned in ultrasonic bath. Good. Now, another connecting question and the most important question which I feel is, if items, so in case of reusable items, we perform all these procedures, that is pre-sterilization or decontamination. But if the items are not reusable, if they are disposable, if they are not reusable, they need to be disposed. And how do you dispose the following items? I'll list out the items and let me know how you dispose them. So how to dispose? Suture needle, blood stained gauze, scrap amalgam or waste amalgam or amalgam flash, old patient dental records. Now, answer each one independently, right? Separately. So how do you dispose these non-reusable materials like suture needles, bloodstained gauze, waste amalgam, and old dental records? Needle destroyer is something which is used in case of your syringes, right? Disposable syringes. Yes. Yes. So incineration. So whatever is contaminated with blood, you want to put them in H2O2. Fine. Thick containers for needles, according to Shoaib. Preeti says needles should be discarded, needles destroyed. Yes, Divya, cube light is flashing on board. I can understand. Anyways, I'll try to minimize writing in this area, right? I'm sorry for that. Yeah, what I've written here is manually or ultrasonic bath. Right. Anyways, I'll try to avoid this area as much as possible. Yes, scrap amalgam and glycerin. First time I'm hearing this. Okay, yes, Ramesh, you can either reuse scrap amalgam, or if in case you're planning to dispense or dispose it off, how do you dispose it? Or how do you discard it? Right. Suture needles. So these are categorized as sharps. So these are collected in black bags and they are sent for incineration. As you said, incineration, isn't it? I hope you can see what I'm writing. Yeah. So blood stained gauze. So any human organic waste, or it can be blood, saliva, they're usually collected in your yellow bags and they are also incinerated or they can be buried. So blood stained gauze, yellow bags. So we'll discuss biomedical waste management, color coding in a separate session, right? And what about amalgam? As Ramesh said, you can go for recycling, or amalgam can also be discarded in your. So how do you discard amalgam? Abhishek, you say we use a jar. That's the same question I asked today. Even I asked my students the same. They said we use a jar which contains some liquid. So you have to be more specific, right? So which jar? Yes. Usually scrap amalgam has to be stored underwater in a closed container, or the best solution that can be used is, I'm waiting for the answer. Yes, good. It can be water, glycerin or X-ray solution, used up fixer solution. Good. Old fixer solution. And what about old patient records? How do you discard old patient records? Yes. So how do you discard your old patient dental records? We'll stop with that and we'll then proceed with the next question. If you're not using digital version, so how do you manually store, how do you discard these old dental records? Archiving. I don't think so. Maybe you'll store it for 1 year or 2 years, but if it starts accumulating, archiving can't be done. So how do you discard? I'm not asking you how do you store. How do you discard? Filing and all comes under storing, right? But if at all your rooms are full with your patient records, how do you discard them? Come on. Ash is the right answer, because patients' dental records are they contain confidential information, so they have to be burned or converted into ash so that they are not readable. They are not readable. So you will either burn them or shred them. right? They should not be readable as it contains confidential information, right? Which patient would not enjoy to share. Why do you want to recycle journal? Okay, you want to save paper? Okay, good. Right, so this is regarding decontamination procedure of pre-sterilization and various devices which can be stored accordingly. Yes, if you give them to you want to eat. Incineration is at very high temperature. Just search it. Incineration is at very high temperature where the remnants also will not be found. Yes, Prerna, you say our mama from college buries the scrap amalgam underground. Once a bottle containing solution is full. So bury it underground. Because I mean, in fact, that should not be done. Burying it underground, again, there is a chance for your mercury to enter into food cycle by any means. There can be release of mercury vapor. It's not advisable as far as literature is concerned. Prerna, what is mini-matter disease? Mini-matter disease, right? Okay, let's continue with our next question. So I have some abbreviations for you. I'll make a note. I'll just write down the abbreviations. You try expanding them, right? Yeah, fourth question. Hope it's not really that visible. I'll use another pen. Expand the following abbreviations. These are all related to your specialties, right? Okay, you have these abbreviations IOTN, BPE, DMFS, small letters, capital letters, INR, ESR, CPITN, and MTA. So try expanding these terms. So Indian Game Guru says lecture in YouTube is how boring. Yes, these are not games, right? These are all discussions happening for some purpose. So obviously it will be boring for a person who is not really interested. You can try games. Samsung, you say. Okay, cool. Right, so try expanding them. I'm sorry, I'm blocking your view. Just try answering as many as possible. Samsung, you can be a bit gentle. If you use certain words, maybe others might feel bad. So rather than saying get lost, you can say please go away. A smart way of saying get lost. Obviously, your intention is asking them to get lost. It's how you deliver things that really matters, isn't it? Farheen says whiteboard is not visible. What about the letters? Okay, just come to your side. Farheen, try to improve the quality of your video, right? So IOTN is, as rightly said, index of treatment needs, right? IOTN is index of treatment needs. What is BPE? BPE is, so anyone explain what BPE is? Yes, Alankrita, good. Yes, Sam, I completely agree. It's never boring. It all depends on our perception. That's true. But also it depends upon how we're delivering it, isn't it? Yes, good, sure, Anjali. So BPE is basic periodontal examination. Yes, and small DMFS, small letters, it's decayed, missing and filled tooth surfaces of deciduous teeth, and the capital DMFS, decayed, missing and filled teeth in case of your permanent teeth. Yes, BPE is basic periodontal examination. And INR, so INR stands for yes, INR, International Normalized Ratio, right? Prothrombin times standardization. ESR, erythrocyte sedimentation rate, as you all rightly mentioned. CPITN, Community Periodontal Index of Treatment Needs, CPITN. And what is the normal value of INR? And MTA is, as you rightly mentioned, it's mineral trioxide aggregate. Simple, right? Yes, it has to be 1. Good. Now let's move on to the next question then. Now this is from oral medicine. Let's test your oral medicine skills also. So the question is on lichen planus. Let me just write down here. Lichen planus is a chronic inflammatory disease. Yes, lichen planus is a chronic inflammatory disease. Which tissues are commonly affected in case of lichen planus? So that's the first question. So lichen planus is a chronic inflammatory disease. Which tissues are commonly affected? Yes, in fact, it's mentioned that oral surgical procedures are completely safe when INR values are between 1.5 to 2.5. Beyond 3, we should exercise caution in extracting teeth. Yes, Farheen, glad to hear that. Yes, you can increase the quality of your video all the time. Right. Yes, it's oral mucosa. I mean, in general, oral mucosa as well as skin. So these are the areas which are affected by your oral lichen planus, right? So oral lichen planus usually affects your skin as well as oral mucous membrane. So oral lichen planus. Now the second sub-question is, which age group is commonly affected in case of oral lichen planus? Yes, Sonal, dermatological manifestations also seen. Which age group is commonly affected? Yes, it's middle age group. True. Over 40 years, 4th decade. That's very true. Good. Now, what are the different clinical appearances of lichen planus? So name as many as possible. We have around 6. How many clinical appearances of lichen planus do exist, and name them? Name the clinical appearances of lichen planus. Yes, nodular, radicular. We can try is a finding, oral finding. Good. Annular, atrophic. Yes, Shruti. Good. So we have different forms. Reticular, atrophic. Good. Erosive, papular, plaque-like. Even dyschromato gingivitis is also seen as a oral manifestation. Yes, good. Now, most importantly, can you list out important histologic features of oral lichen planus? We have some characteristic histologic features. So, name few histologic features which are characteristic of lichen planus. Very good. Sawtooth. Yes. Sawtooth ridges or radipex. Max Joseph clefts. Hyaline or civet bodies, if you remember. Tombstone appearance is not as such seen here, but you will see basal cells being infiltrated by lymphocytes, juxtaglomerular or juxtaepithelial infiltration by lymphocytes. Yes, civet bodies, good. Yes, so there can be hyperkeratosis or parakeratosis, sawtooth retipex, band-like lymphoplasmacytic infiltration, juxtaepithelial. Yes, and hyaline or civet bodies. Good. Yes, Subhashri. Good. Well, now finally, pertaining to oral lichen planus, name another connective tissue disorder that can give rise to intraoral lesions which are similar to lichen planus. Name another connective tissue disorder that can give rise to intraoral lesions similar to lichen planus. Yes, there is liquefaction degeneration of basal cell layer, as Preeti has rightly mentioned. Liquefaction degeneration of basal membrane. Also, we'll have some image-based discussion pertaining to the same, right? We can understand it much better. Connective tissue disorder. It's not leukoplakia here. Okay. Lupus erythematosus is a connective tissue disorder that can have similar clinical presentation to that of lichen planus. I mean, there can be very differential diagnosis, but the connective tissue disorder that gives intraoral lesions similar to lichen planus, right? Lupus, just have a look. Lupus erythematosus, right? Now, finally, we have one final segment pertaining to oral surgery now. What signs and symptoms would make you suspect that you have created an oroantral communication following the extraction of an upper first permanent molar? The question again, what are the various signs and symptoms that would make you suspect that you have created an oroantral communication following the extraction of an upper first permanent molar. Good, there can be regurgitation of fluids, but intraorally, when you observe intraorally, obviously there will be a visible defect, right? So oroantral communication I hope you can see. There can be a visible defect or antral mucosa, and also there can be hollow sound when suction is used. Right, so these are some of the signs and symptoms of an oroantral communication. Yes, a visible defect or antral mucosa visible, hollow sound when suction is used, water discharge from nose, air while breathing. Yes, mouth mirror test, right. Now, how do you manage this oroantral communication? How do you treat it? If you created an oroantral communication, how do you treat it? Obviously, surgical closure of the defect by approximating the palatal and the buccal flap, but usually the defect cannot be closed by approximating. So what we do is we either reposition the palatal flap, palatal rotation flap, or we'll reposition buccal pad of fat and then try to close the defect. So surgical closure of the defect by approximating palatal and buccal mucosa, but there is usually inadequate soft tissue. So there can be buccal advancement flap alone, or with buccal pad of fat or palatal rotational flap to garner additional soft tissue support to close the defect. And also we advise the patient not to blow from the nose for at least 10 days. Yes. Yes, we have a criteria, less than 2 mm, leave it. Okay. If at all a root is pushed into the antrum, into the maxillary sinus, how can you gain access to remove the root once the socket had healed completely? Next question is, if a root is pushed into the antrum, how can a surgeon gain access to remove the root if the socket is healed completely? Good, Mariam. Sam, wonderful. Sonal. That's nothing but a Calvel look operation, right? So you raise a flap in the buccal sulcus in the region of your canine and premolar and then remove bone. Calvel look procedure. I'm running out of space. It's not hell, it's Calvel look. Calvel look procedure. Obviously, it's going to be hell for the patient. Okay. So these are some of the SAQs, self-assessment questions, which I wanted to discuss in this video. Right? So I've gone through the Kennedy's classification, very simple, but you can have a different way of presentation altogether, right? They can give you the tooth existing in a patient in this format, and they can ask you to classify the arches accordingly. And also I discussed few important points pertaining to microleaches, consequences of microleakage and how to avoid microleakage. And also I discussed what is pre-sterilization or decontamination and how do you dispose various materials commonly used in our day-to-day practice. And also we have expanded few abbreviations. We have discussed few abbreviations and also a few important relevant points pertaining to oral lichen planus, the histologic findings, clinical presentations in brief, and also have gone through oral-enteral communication. And often we have this question, how do you manage a case of oral-enteral communication, right? Yeah. Yes, Sam. You need not be sorry, right? You just got angry seeing this coming. Maybe you'll get used to it. Try attending our live sessions regularly. You will see one or two even talking ugly words. In fact, the person who came now used some decent words. We even have few profiles using very bad words. Yes, Sonal, it's interesting this way. Anyways, I just wanted to try in a different format because I'm getting used to the same format and I'm feeling really passive. So I felt like maybe I should try different. So I've come up with this idea of SAQs. So I hope you enjoyed this session. That's very important. And I hope it's not really that boring. I know without music and all, it's obviously boring, right? And without toffee, it's obviously boring. Okay, right. So we'll have more of such sessions, right? SAQs. So you can have this active learning, and which gives us more and more confidence in the process, which gives you more and more confidence in the process. And I tried to improve the lighting also, but I'm sure it's not still very much impressive. You can see some white streak of light here. I'll see if I can avoid it. If in case I can't, at least I will try avoiding writing in this area, right? Okay. Yes, Farheen, glad to hear that. So we still have 33 watching with 3 likes. Good. Yes, because with options, it's like we're being conditioned to think in a specific way, right? So these are all open-ended questions. Open questions where you will have scope for better learning, right? Anyways, I'm glad that this way of discussion worked out. So we'll try to have more of such sessions, right? So before concluding, Toffee is not feeling well. So we'll say hi to Toffee and then we'll conclude, right? Toffee. Yes, Farheen. You can try watching it. It's a very brief video, right? Oh, it's already 50 minutes. You can just remove the first 10-minute part. Yes, in fact, options do create confusion and they're even more challenging to answer when you have options. So she is not feeling well. She has just vomited twice. She has eaten some leafy vegetables roadside. So how are you, Toffee? Yes. Okay then. Okay, I will see you again tomorrow with image-based questions, right? Image-based questions. And you have any further questions, you can drop them at howtobedentist@gmail.com. And I hope you have gone through the video active learning. So I hope you're following it. And also try not to ignore your retrograde schedules, right? So do not neglect them. I've been following retrograde schedule. So you can either go retrograde or you can plan your day and proceed accordingly, right? And also you can mail me those schedules so that we can have some discussion and see whether we can have any better improvement if necessary. Yes, Toffee. She is looking at the monitor. She is looking at your comments. Yes, Sonal. I'm sorry, I got confused with another Sonal. I have another student, Sonal, who said she has like her cousin's marriage, so I just got confused. Yes, Sonal, definitely we'll have more videos on medical subjects also, right? Yeah. Yes, bye. Good night. See you all tomorrow morning at 5 o'clock, right? Take care. Yes, Sam, you're all welcome. Welcome, everyone. Good night. Bye.